Great. I think folks are still sort of trickling in, but we can get started at least with some of the basic introductions, being respectful of everybody's time. So thanks to you guys who have introduced yourselves in the chat, and I encourage everyone to do that just so we know where folks are from and what your role in respite might be. Really excited to wrap up this clinical webinar series today talking about incontinence. It's not always the easiest topic to talk about, but it comes up a lot. I think it's one that's important for us to think about and consider in medical respite programs. So I'm really happy to see you all joining us here today, finishing out this series that we've done. I am going to share a link in the chat. This link is to all of the recordings for the webinars will be posted to this link. We have the ADL one up so far, but all of them will be posted. You'll also be able to find links to the clinical guidelines that have been published along with these webinars. And then we'll be posting all of the PowerPoint slides as a PDF for your reference as well. So we'll probably have those up within the next week or two. So feel free to check back for those resources. The clinical guidelines are posted and ready for your use to be shared with programs. So feel free to check those out after today's webinar as well. And for now, we'll go ahead and jump into our content here about incontinence. So hopefully our objectives for today, at the end of this webinar, you'll have a better awareness of what is causing incontinence, and especially what issues are more likely to cause incontinence for people experiencing homelessness. And then also thinking about what our role can be in medical respite and recuperative care in supporting people in incontinence management and what strategies we might be able to use to support these individuals. I'm just going to do a short disclaimer that we use the term medical respite and recuperative care interchangeably. They represent the same service. I likely will default to medical respite, but just know it encompasses all programs, however you identify here. So I'm going to start with just level setting on what is incontinence. So incontinence is any non-intended loss of urine or stool. This can be in large or small quantity. And what's interesting to note and really, I think, important about this topic is that it's actually really prevalent among the general population. In the United States, about half of older adults have experienced some form of urinary leakage or accidental bowel leakage, and 25% have experienced this at moderate, severe, or very severe leakage rates for urinary incontinence, and about 8% for moderate or severe bowel incontinence. So this is actually a big issue in healthcare in general. It tends to be under-identified and undertreated, which is really unfortunate because it is actually a relatively treatable condition through different behavioral health, or I'm not sorry, behavior strategies, medical strategies. And so it's really something that's uncomfortable and embarrassing for folks, but can actually be really well treated when it is brought to the attention of providers. And so I want to also talk about what is incontinence versus what is incontinence management. So incontinence itself is the physiological action, right? That definition of someone experiences a leakage in their bladder or their bowels. This can be caused by medical conditions or a person's overall health. It can be caused by medication and side effects, psychological conditions, including and especially trauma, and then the environment. And what I want to differentiate is what incontinence management is. And that's the person's ability to respond to the existence of incontinence, their ability to acquire and use products to help management, using routines and strategies, exercises such as pelvic floor exercises, engaging their medical provider. And this really requires access to supplies. And so I want to point out these differences because I think sometimes, again, when we're thinking of these things, if you're at the ADL webinar, I touched on this as well, sort of black and white. Like if someone's incontinent, we're not able to handle them in the program. And sort of changing that paradigm to think about many people are living with incontinence, and what might be differentiating factor is if they're able to manage that incontinence, or is incontinence management a reasonable goal for this person, as opposed to just sort of the existence of this physiological condition, because it's affecting so many different individuals that if we say, if this is in your problem list, we can't take you, versus whether or not the person is able to manage it. And what you'll notice actually if you're reading reports from hospitals on the functional independence measure, folks will be identified as an independent in incontinence if they're able to manage it independently. And so that might be a space where there's discrepancies happening, where in the hospital, the person has managed the incontinence and they come to your program and they have this issue and you weren't aware about it, is that some of these tools measure it a little bit differently. So that's something to think about and watch out for as well. There's different types of incontinence that a person may be experiencing as well. These are sort of the definitions of that, but stress incontinence is really just an involuntary loss of urine. Urge incontinence is an involuntary loss of urine, but also accompanied by a strong desire to void. And so people suddenly, all of a sudden, feel this intense urge or pressure to use the bathroom, and it kind of comes out of nowhere. And it can occur while a person's awake or while they're sleeping, and it can happen in large amounts at sort of unexpected times. There's also mixed incontinence, where the person may have extreme urge, also leakage. And this is what happens when people suddenly feel a strong urge to go, and then also will have a loss of urine accompanying that. There's also overflow incontinence, where there's a loss of urine because of overdistension of the bladder. Essentially, the bladder is so full that it overflows. And this can be because of environmental lack of access to a bathroom, but depending, there might be medical conditions where the person doesn't have the sensation that their bladder is too full and don't realize that they need to use the restroom. And then there's functional incontinence, which is really more other factors influencing the limitation in being able to urinate, which can be cognitive functioning, decreased awareness, or physical functioning. So folks may know and recognize and realize when they have to use the bathroom, but have barriers to getting there in time, such as mobility impairments, decreased sensation, inability to unbutton clothes quickly enough. So these are things that are associated as functional incontinence, that if they were not there, the person would not be experiencing incontinence. And there's a lot of different things that can cause incontinence, which is partially why it's so prevalent across the population. So I think a lot of times the first thing we think about is if the person has a UTI, but there are other factors too. So interestingly, for urinary incontinence, that can actually be caused if someone is constipated or has chronic constipation. And so that's an issue that, if resolved, might resolve the urinary incontinence issue. Anybody who's had any sort of injury or medical condition in that pelvic region, whether it's spinal cord, bladder, prostate, any sort of pelvic injury may have issues with incontinence, as well as folks with osteoporosis, people who have decreased sensation, and then people who have diabetes and other endocrine disorders may struggle with incontinence as well. And then medications can actually be another rather large cause of incontinence. It can cause changes in frequency and retention for individuals. Some medications that are more likely to cause this are those that are used to treat depression, psychotic disorders, diuretics, sleep medications, and blood pressure medications. So when we're thinking about our population, especially with a lot of complex comorbidities, when we look at their med list, it's interesting to look at and see how many medications could be possibly contributing to incontinence. And then medications that cause constipation. So like I said, constipation can actually result in urinary incontinence for folks because of the pressure that's put on the bladder. And people can have that again as a side effect, especially from pain medications are known pretty well to do that. And then we're talking about bowel incontinence. There's also medications that can cause, diarrhea, such as antibiotics, metformin, and stool softeners. And sometimes people have difficulty because they need the stool softener to make it easier to go, but it also can increase frequency, and sometimes that becomes unmanageable. So these are all different things to look for, and stool softener might accompany a pain medication, but be working almost too much or too well to address that problem. And then there are medication interactions. So sometimes it's not just one, but sort of that combination of medications that's resulting in the incontinence. There's additional physical barriers. I touched on a couple of these, but for folks, if they're not able to get to the bathroom on time because of mobility limitations, whether it be using a wheelchair or a walker or just a slower gait, having difficulty getting undressed quickly enough, especially for folks who have that urge incontinence, there's suddenly this urge and this anxiety around getting there to go. And if you have trouble with that fine motor difficulty, can result in having an accident. Inability to open and use disposable underwear. So sometimes people have the supplies, but however the packaging is, it makes it hard, especially if you can't unpackage it and just sort of have it at the ready. Mobility limitations. Positioning and posture is actually really interesting for folks who are in inappropriately sized mobility devices. So many of our clients who access wheelchairs through any number of means, that posture and sort of being slumped or not being supported or being able to sit upright can actually put a lot of pressure on the pelvis, and for some folks can be a cause of incontinence. Decreased cognition. Again, people who are in early onset of dementia may have trouble with this, but if your cognition is impacted by other factors, such as medical, medications, whatever might be going on, it may not be permanent change, but that decreased cognition can make it more difficult to manage continence. It can also affect body awareness and recognizing there's that sensation to go, or even remembering when was the last time I used the restroom, maybe it's time to go again just to avoid a problem. And then psychological things can also contribute to incontinence. So trauma is a really big factor. Both having a recent trauma can increase incontinence and a history of trauma. And what the research shows is that folks who have a history of sexual or physical trauma are more likely to experience incontinence, not just as children, but also as adults. Stress, ongoing stress can increase incontinence. Anxiety has been found to have a higher prevalence rate of people experiencing incontinence than some other psychiatric diagnoses. Substance use, which can be active substance use, so if somebody, especially alcohol use, is associated with incontinence, but also folks who might be going through withdrawal can experience some of those symptoms as well, especially fecal incontinence and diarrhea. And then what the research, it's very preliminary, is finding that a mental health diagnosis can actually impact some of those hormonal and chemical levels in the brain that also act on the bladder. And so the association and relationship is not totally clear yet, but just knowing that there is the existence of a mental health condition can increase that risk of incontinence, both by having the condition and also the medications used to treat it. And then the severity or acuity of mental health symptoms, again, folks who may be really significantly experiencing symptoms of depression, that low motivation, slower movements that happen with that can result in having incontinence as well as that decreased awareness. And then this is the one that I think is going to be the most relatable. Well, all of it's relatable, but when I was thinking about this and learning about all of the different environmental factors that result in somebody becoming incontinent, I was actually pretty angry thinking about how much the circumstance of homelessness contributes to this and is causing this for individuals. So a major cause of incontinence can be lack of fiber in the diet, both for the digestive tract, again, in relieving constipation, that pressure on the bladder. Dehydration is another significant concern. Not drinking enough and not being hydrated enough results in a buildup of salt in the bladder, which is an irritant and can contribute to incontinence. So folks who don't have access to enough water during the day, and happens a lot with our folks because they may avoid drinking water in order to not have to use the restroom if bathrooms are not available to them throughout the day. And that results in that inconsistency in routines for toileting. We think of, incontinence can be caused by experiences of having to hold your bladder for a long period of time. Folks who are in the medical field, sort of like nurses syndrome, right? We're so busy, we don't have time to use the bathroom enough during the day. But when we think about it to people experiencing homelessness, they may be required to hold it because there's not a bathroom to use. And I think this became even more excessive during COVID when public facilities and restrooms were closed and people just had nowhere to be able to use the restroom. And that can over time result in incontinence. Disrupted and inconsistent routines, again, not knowing when reliably you can use the restroom changes your habits about when you're eating and drinking, and not enough time to really effectively void the bladder. So if you're urinating in a public space, trying to do it quickly so no one sees you, it doesn't result in bigger problems, you may not be emptying the bladder, and that over time, again, can build up and cause issues. And then not being able to access supplies. Some of these supplies are available through a person's insurance, but it depends on if you have the diagnosis, if you're getting treated for the condition, and they're actually relatively expensive. So a pack of Depends that would last maybe 3 to 4 weeks is about $40 just for one of those. And so if you need more than that, it adds up over time and is really not affordable for a lot of people. And then accessibility of bathroom spaces. Again, if you're relying on publicly available restrooms and you have mobility devices or mobility concerns, you just may not be able to safely get to the bathrooms or, again, get there on time. And then there's also, all of this contributes to an increased risk of UTIs. And so then that increases pain, it increases urgency, and then you don't have the things you need to be able to treat it effectively. And then being able to take care of yourself. So having adequate supplies of toilet paper, being able to complete hygiene, toilet hygiene, and then just general hygiene. So if you don't have a place to wash yourself or your clothes after having an experience of incontinence, that sort of sticks with you and contributes a lot to the bias that people experience. And this is true for the general population and certainly for our population as well, that when folks have incontinence, it's been identified that there's decreased social and community engagement. People are embarrassed about how frequently they have to use the restroom. They don't want to be around others in case there's an episode of incontinence, or be away from where they know they can use the restroom. And then stigma and poorer treatment, right? I think the automatic response, if somebody appears soiled or smells soiled, right? People cover their faces, their mouths, they don't want to engage with them. The provider might want to have a shorter visit with them because of the odor, but really it's because the person doesn't have adequate supplies to take care of the issue. And that makes people avoid care and being around others a lot more frequently. And then people will limit their routines. So people might not be willing to ride the bus for more than 30 or 45 minutes out of fear of not being able to get off and use the restroom in time, or to be away from the space where they know that they can do that. It also increases risks of falls, both in the community and if the person is housed. So having incontinence is a huge risk factor for falls, even in our younger adults. Also can result in sleep disruption, especially if frequency is an issue. Dehydration, again, I spoke to that. If people are afraid of having incontinence episodes, they'll drink less, which unfortunately exacerbates the problem. And then not drinking, not eating, to avoid that issue can then increase the side effects that they might experience, or make it more difficult to manage some of these conditions that require eating and drinking. So considering diabetes is, diet is a huge part of that management and can be impacted if somebody's also dealing with incontinence. And then folks might have skin irritations and infections, especially if they don't have clothes to change into or a way to clean their clothes. That can increase their skin integrity, can result in wounds, and then also increase risk of infection. So there's a lot of factors as to why it's really important to address incontinence. So kind of spoke to all the environmental factors that impact our clients. There's a little bit of research. There's this great group in California who's been doing a lot of research on older adults. But what we know, again, is that people experiencing homelessness experience geriatric conditions 10 to 25 years earlier than their housed counterparts, which means that something that affects 60 and 70-year-olds in the general population, we're seeing in 40 and 50-year-olds. So it's not something that we want to reserve screening for people who are older, right? We need to be thinking about it with anyone we might be seeing. In this particular population where they did the research, the average age of folks was 58, and 48 of them screened positive for urinary incontinence. So that's a really high prevalence of that issue within the population. And again, with adults who are a little bit younger than we might typically look for that. Incontinence is a significant contributor to falls in older adults experiencing homelessness, so general population, but our population as well. And that's significant because falls can be a reason why people are not housed and live independently, because it can cause further injury, it can cause functional limitations, and sort of this downward trajectory that people are then institutionalized much younger in long-term care facilities, as opposed to being able to remain in the community. So a lot of implications as to why this becomes a bigger issue. Sort of a summary of all of these things kind of wrapped together, right? We know that there are higher rates of chronic and acute conditions that can contribute to incontinence. We know that people may be more likely to be prescribed and taking medications that can increase incontinence. And then that whole environmental piece of not having a safe place to use the restroom and access incontinence supplies, and they're not accessible. We don't have time to void our bladder. And then there's, public and legal consequences for that, right? If folks don't have access to a bathroom and are having to do this in public spaces, they can get citations, they can get arrested for indecent exposure, and all of these things related to a medical physiological condition. So it's a little bit of a health justice issue as well. And again, thinking of all of these factors that might be impacting our folks, lack of access to nutritious foods and even just water, right? So even if the person isn't intentionally avoiding water, do they have a space to get enough water during the day? And it's really hot across the entire country right now. So really important to think about people's hydration needs, both for their safety, but also for their long-term health. Again, that access to supplies piece, and a place to discard the used supplies. So this also becomes an issue. Again, this is something that people tend to be a little bit more embarrassed about. And so they may avoid using certain supplies if there's not a place to get rid of it discreetly. And being able to have your clothes and wash them and clean them thoroughly, and just contributes to that bias and stigma that people already face. And I think incontinence is tricky because in a lot of spaces, in particular shelter settings, but others as well, sometimes incontinence is considered to be a behavioral issue, which is really unfortunate because we've just seen there's a myriad of reasons as to why it could be medical. But if it's treated as a behavioral issue, it doesn't help resolve the problem and really just increases that bias and stigma. So why are we thinking about this in medical respite, right? Where does this fall into what we're doing? One thing to think about is that the folks coming to respite or referred to respite may be more likely to have issues with incontinence because of acute medical needs and co-occurring chronic issues. The other thing is that folks may be referred who have incontinence because incontinence alone is not a reason for someone to be referred to long-term or higher levels of care. So it's not necessarily a reason a skilled nursing facility will accept someone if there are not other barriers in existence. And so folks may be managing this or dealing with it and not qualify for other levels of care depending on their functional needs. The other thing to think about is that shelters are really less prepared and trained to address and manage incontinence. That's a place where I've seen it treated as a behavioral issue. People are kicked out over it. They just don't have staffing and training to be able to address it well. Also, unmanaged incontinence increases fall risk. So this is another preventative health measure that we can take to increase the quality of life for individuals we work with. And then not having a safe place to do ADLs and take care of themselves can really further any risk of infection, UTI, that may be coexisting for individuals. So these are all things that potentially could be addressed within the respite setting. Some things to think about too, it can be in response to an acute hospital event, and that therefore could be a new issue for the person. So again, treating it in respite gives the person an opportunity to develop self-management skills to take care of that part of their health. And sometimes, again, I know sometimes referral sources will refer people who are inappropriate or not document certain things, but there may be a point where the incontinence is unnoted because the hospital has more resources. The person may have had a catheter and that was taken out a couple of hours before they discharged. So that issue actually wasn't really recognized until the person transitions back to the community. It also may be a chronic issue, but limiting other opportunities. I've certainly seen it as a barrier for folks to getting housing. That again, if the person had opportunity to develop self-management skills, it wouldn't really be an issue anymore. And again, results in that early institutionalization. Sometimes skilled nursing does not always address incontinence. They just sort of treat it as a chronic condition the person is going to have and will do a lot of compensation for it, but not teach people how to manage it independently. And so medical respite, again, could be a great place to address some of these underlying causes through medication reconciliation, opportunity for self-management, identifying how to access supplies in the community that can really support the person once they transition out of the respite setting. But just like all of these things, if we're thinking about how to reframe this and how do we potentially do this differently in our program, and are we going to change our admission criteria, there's some things that we need to think about, right? The answer is not always easy in respite. There's always a lot of gray space that we have to think through of what fits best. But some things to consider is who do you have on staffing and who would be appropriate to support continence management with people who come in with incontinence needs. And what type of incontinence can we manage? So managing urinary incontinence may be an easier lift and have more staffing available than somebody maybe who has bowel incontinence. That might be a line that you can shift there. What can we manage safely and hygienically within the space that we have? And can we consider this a coexisting condition that can be treated as opposed to an inclusion criteria, and shifting our thinking in that way. And thinking about it as a health equity issue. The more I dove into this, the more I see it's such a health equity need for our general population that's living with this, but really are folks who might have incontinence as a result of 100 environmental factors, as opposed to anything behavioral or volitional that they're doing. So thinking through what steps can we do to help support people better within our program that are dealing with incontinence. So I'm going to provide hopefully some suggestions and some ways that you can think about doing this that can be incorporated within your programs here. So first and foremost, I think the biggest thing is to continue to use our trauma-informed care approaches, especially because we know that trauma and sexual trauma can be present and contributing to what's happening with the incontinence. So the trauma-informed approach is always really critical, but this is a space where people feel very embarrassed, very uncomfortable, and may have these histories of trauma that it can be really hard to talk about what's happening with that part of their body. People can also feel really vulnerable when having these conversations. They might fear housing loss or not being able to move into housing because it's an issue. They might also be afraid of moving into institutions or long-term care facilities. So people might be hesitant to talk about this issue, both because they're embarrassed, but because they know what it might mean to acknowledge that this is something that's happening. People might also avoid structured activities where they can't have bathroom breaks. So thinking of, somebody might not want to go to a group program, day program, recovery program, where you're expected to sit in group for an hour at a time and you're not allowed to leave the room, or only one person's allowed to leave at a time, right? So then you don't know that you can leave the bathroom when you suddenly have this urge. People may be really resistant to engaging in some of those spaces because of that. I think we need to keep that in mind when we're making some of these referrals for folks as well. And then also, people have concerns, again, about safety, legal involvement, and arrest, especially if they are living in public spaces. There's a lot of fear and anxiety attributed to that, and there may be some trauma related to those. So just in general, when we're considering any of these approaches and strategies, I'm going to go through just making sure that conversations around it are private, and that it includes people that the person is comfortable sharing with. They may not really be comfortable with every person on staff knowing that they're addressing and dealing with incontinence. They also might have a support person that feels better to have with them in the room to talk about it, and really need to talk about if it's going to be addressed and strategies are going to be implemented. The client needs to consent to who is going to be supporting that. If there are CMAs and techs within the program who are going to be supporting that, be upfront with the client so that they're not surprised when somebody comes up to them and says, hey, are you following your bladder schedule today? That can be really off-putting if they don't know that's going to happen. So just making sure that when we're talking about these and working on these things, the clients are driving it and are consenting to that conversation. Making sure people have private spaces for self-care and toileting. Even in congregate spaces, there are some strategies to help people be really discreet about managing these different issues. And having a space where people can discard incontinence supplies, right? So people don't want to discard a used Depends in an open trash can, one, where people might know they're using them, but two, for hygiene purposes. So do you have individual baggies? Do how can people take care of these things without other people seeing and knowing that that's what's happening? And sometimes all it takes is a small trash can in every bathroom stall just to be able to do that. So working as a team, right? Medical respite, we're really great at working collectively and collaboratively. So again, communicating among the team with the client consent, being consistent in approaches is really critical, and use of strategies. And using universal language, and I think using appropriate language. Nobody wants to hear, oh, so-and-so peed himself, and then other residents in the respite program hear that. So using medical appropriate adult terminology that's not embarrassing for the people involved. And then also being that support between the person's primary care and specialty providers to acknowledge what's going on, to maybe treat it, especially if their medical care isn't happening in the respite setting. So engaging the client, right? Motivational interviewing is a pretty foolproof approach to addressing what the person's concerns are, what do they identify to be their issues? What are they willing to do? What do they think potentially needs to change? And this is just an example of some trauma-informed questions that you can ask to start the conversation. There's certainly other ways to do it, you know, and doing what's comfortable, but, you know, just really asking some questions about what's happening, right? Do you have a hard time getting there on time? You know, do you feel like you need to rush? Do you have what you need to take care of yourself? This can help you start to identify what strategies might be most appropriate to start out with to support the person. And different providers and roles can play, different roles in this. So nursing can do basic assessments and questionnaires, you know, building that rapport and identifying what the person's needs are, gathering data, right? Helping the person identify what's happening, how frequently is it happening? You might observe what's happening, and then support to implement strategies, and also assessing for dehydration, because that can be such a co-occurring issue when people are experiencing incontinence. Medical providers, whether within the respite program or primary care providers, can do an initial exam to address what might be causing it, you know, sending for testing such as a urinalysis or stool studies, ruling out the, you know, infection, which happens a lot frequently, even mildly can cause a lot of problems, and making referrals to appropriate specialists. So, you know, if it's a result of diabetes, is the person plugged into their endocrinologist? You know, is there a heart issue going on that might be causing this? So making sure folks are seeing who they need to address it. And that medication reconciliation piece is so key, right? So, you know, Courtney talked a lot about last week about simplifying regimens. And when we're doing that, thinking about what side effects are manageable for the person, you know, a temporary side effect of incontinence may not be a big deal for someone who has regular access to the bathroom, but for somebody who doesn't, that's a huge deal. And so thinking about that and what we're prescribing. And then again, our case managers and community health workers and peers provide such a critical role in building rapport with the clients, identifying what their concerns are, and thinking about how do I access long-term resources and supplies? How do I get these from the pharmacy? How do I navigate insurance to have them help pay for some of these supplies? How do I pick them up discreetly? How do I talk to my provider about what's going to happen and sharing that this is a concern for me? So really robust ways of supporting the person, and identifying nutrition resources as well. You know, if the person needs to increase fiber in their diet, how and when can they do that? And then behavioral health, certainly in that initial engagement, especially if some of the incontinence is related to anxiety or trauma, being able to address that, but also, you know, in terms of doing some behavior change. This can be a hard shift for folks to change what they're doing and how they're doing it, and that can be a great support. So again, this is kind of what the nursing and medical provider exam might look like: a history, gathering symptoms and associated factors, doing a physical exam if the client's willing. And this is a whole list of questions. I have a couple of slides on it. I'm not going to read them out loud to you because you'll have the resource of the PDF after today, but these are just some examples of what the medical provider can ask during the history and physical to help identify and differentiate what type of incontinence the person is experiencing. So again, if it's, you know, an urge incontinence or stress incontinence, sometimes the strategies are a little different, or it helps identify what medications might be contributing to it. So how often is it happening? When does it happen? You know, is this happened to you before? Is it happening overnight? How much loss are you having when you leave? All of these questions, you know, do you have trouble getting to the toilet on time, and why? And that can help identify, again, some of these referrals that folks might need to have as a result. So again, I won't read them all out loud because I know you'll have the printed version of this, but there's a really specific approach that can be taken to help identify what's going on and identify appropriate resources for that. Great. And so there's a few tools that can also help guide this. The International Consultation on Incontinence Questionnaire, that's a tongue twister for you this afternoon, has a lot of resources available. So this questionnaire is available for free at the link here. They actually have a pretty robust set of modules that folks can take and follow-up questionnaires, and some that are specific to different gender identities and different issues going on. So I would look into this, especially if you're looking at taking a more holistic approach to this in your program. It's a really great resource to be able to address this issue and dive a little bit more into it, especially if you haven't managed this in your practice before. And it's nice because it looks at sort of the whole lower body system, urinary tract, vaginal systems, and lower bowel dysfunction. There's also the 8-item overactive bladder questionnaire, which is much shorter. It's also available for free online. It has been validated in primary care settings. What I will say about both of these tools, neither of them have been specifically validated for people experiencing homelessness. But in the primary care setting, this is a short screener that might be an easier space to start. But as you know, it only really talks about bladder, so it may not identify some of these other problems that are going on. So I'm going to talk through some approaches that you can take just to support individuals in managing incontinence and what those individualized routines and programs could look like. So the first thing really to do with anyone is to track the incontinence episodes. So what is the frequency, figuring out what potential triggers might be, and times of day that it's happening. There's 2 free diaries that I've linked here that are available that you can start to use to do that. And it sort of allows the person to identify when it's happening, what did they feel, and what are some things that happened before that, like what did I eat for breakfast, or what activity was I doing? And that can help identify potential triggers or things that might be contributing to it. That happens routinely after I take my medication, but it didn't happen the day I missed my medication. Maybe that's can help rule out what might be happening. And then prompting the person to set a toileting schedule. And you can, if you have potty trained a toddler, it's sort of a similar approach, but there are ones that are developed specifically for adults that feel more appropriate in talking with adults about it. The first thing you can do is use that diary, that bladder or incontinence diary, to identify when the episodes are happening and how frequently they're happening. And then you set the schedule around that. And I'll give an example in a moment of what that can potentially look like. But use the data that you've collected to identify how often does the person need to go to the bathroom to avoid or prevent some of these issues from occurring. And then setting routines, again, being within the respite setting is a great place for folks to reset routines that maybe have been disrupted by hospitalization or just sort of disrupted because of circumstances surrounding homelessness. So that stability of respite is a great place to sort of get control of some of these things. So, folks can eat meals that maybe relieve constipation and sort of reduce that as an issue. Routines around medications, noticing like if a medication is unavoidable to take and is causing incontinence, can I take it in the morning instead of before bed so that that's not occurring at nighttime? And for some folks, this also means limiting drinks 2 hours prior to bedtime. But again, that's if that nocturia, that nighttime incontinence is occurring. So this is an example of a bladder diary, one of the ones that's linked, and you can see here where the person can write in what fluids they had, what foods they eat, how many times did you use the bathroom, how much did you relieve when you did, all of those kinds of questions. And this can be really helpful if the cause of incontinence is unclear. Doing this can really help with that differential diagnosis. And again, identify maybe some specialists that need to be used to help figure out what's going on, or even just to prepare the person for talking to their primary care provider about it. They can bring this with them, and it's a lot easier to report when it's written down. And again, extra support in the respite setting, you may be able to help the person kind of go through this and reminding them to fill it out, or even if they need some support for filling it out. So it's not super complicated, but there is a lot of lines on it. And so sometimes that health literacy piece can be tricky. And then this is an example of what developing a schedule for someone might look like. So you want to identify the frequency that urination or incontinence episodes are happening. And then you plan and schedule those bathroom visits at an interval that's shorter than what was identified in the diary. And then stick to the schedule. That's the important part. Even if the person isn't necessarily experiencing urge, then we're retraining the bladder and sort of we're reteaching it and gaining control over, you're going to respond to me, you're not going to drive things for me anymore. So teaching that bladder to sort of work and operate on these routines and systems. And then the person over time can gradually increase the time between bathroom visits. So once the incontinence starts to get managed, they can sort of build and increase that time. It's like exercising a muscle essentially and building that strength. So what that might look like, somebody filled out their diary and noted that they had extreme urgency and an episode of incontinence every 90 minutes. So they're noticing this sort of every hour and a half, this pattern of this really extreme urge happening and not being able to get to the bathroom on time. So then based on that, the schedule meant the person was going to go to the bathroom every 75 minutes, whether or not they were experiencing urge or felt like they had to go to relieve their bladder. And that's to avoid that episode of incontinence, but also to, again, sort of train the bladder that it's not in control, the person is in control of that. And this can be done using a written schedule. People may not want this publicly displayed, but maybe for themselves for reference, more discreetly could be done through their phone by setting alarms or alerts to do that. And then if the person's agreeable, prompting from staff or providers to help them remember to implement that schedule. Supporting people in increasing the awareness of urge. So again, that can be done through things like mindfulness meditation, again, through the bladder diary, and just having them notice if the incontinence is happening every 90 minutes, having them practice sit and pay attention. How's my body feeling? Am I distracted when things are happening? When this happens, what am I doing? Just noticing and being more aware of what their body is telling them. And helping to delay urge. And this is kind of scary for people to try to do, especially if they're in a more public or congregate space. But really, when that intense urge happens, instead of rushing, stopping, slowing down, taking a deep breath. And if the person has learned pelvic exercises from a qualified provider, doing those to slow down. And that really actually reduces risk of fall, and over time can help the person have control over that urge and eventually eliminate that intense urge that they're feeling. The other option too for folks is double voiding. So sometimes if the bladder's not emptying fully, people don't necessarily feel that. And so it's using the bathroom, standing up from the toilet, sort of, increasing posture, and then sitting back down to use the bathroom again, or for men, if they're standing up, just to pause for a moment and then to try again to make sure that the bladder is really, truly empty. And that can help avoid irritation by having urine sort of sitting in the bladder as well. So this is an example, again, of what it looks like to delay urge for folks. So the person will feel the urge. Instead of rushing, they stop to take a breath. Again, pelvic floor contractions are useful, but need to be taught by a qualified professional. So if the person hasn't learned how to do pelvic floor contractions, the stopping and taking a deep breath can still be really effective. And then slowly continuing to the restroom. Again, this can be really scary for people to try, especially if they've had incontinence. And so this might be a good one to start if the person's comfortable while they're using supplies such as Depend, so that if an episode occurs, it doesn't ruin their clothes or result in needing to take a shower, or making sure having the person practice this while they're in the bathroom, so that they're really close and able to get there. But the goal is really, again, to reduce incontinence, but reduce that risk of falls that happens from rushing. And then setting up the environment. And this is a little easier in respite programs than the situations our folks are generally living in. But just making sure that bathrooms are available throughout the day. This can be sort of an advocacy piece in your community. In general, a person should not have to hold their urine for more than 4 hours. So making sure the person has access to a bathroom to use at least for within 4 hours of time. And then again, making sure that your facilities have adequate supplies. Do people have what they need to complete toileting hygiene? Are we well stocked with toilet paper that works well? Do we have disposable bags so people can tie up things and put them in the trash receptacles, making sure those are taken out really frequently, and coaching the person when this is identified as an issue about what they can do about it in your space that's acceptable and safe. Because sometimes people don't know if you've been staying in other facilities, or if you've been sleeping on the street, you don't necessarily know what the best way to do this is. Having an access to appropriate incontinence supplies and a variety. So just being mindful of all different types of anatomies and sizes that might be presenting, durability of them. There is a difference in quality, a variety of sizes. There's a variety of thicknesses and absorbencies, but people may be comfortable wearing a thinner absorbency that's changing it more often than a thicker one. So having a lot of options for folks to figure out what's most comfortable. That also might get a little bit of buy-in for people who are really nervous about doing it and thinking that it might be noticeable that they're wearing it, to have them have space to try that out and start to feel comfortable with it. And then I think, again, most respite programs have this, but just making sure there's access to laundry facilities and supplies to clean clothing, especially immediately after an episode happens. So, even if there's sort of this routine, laundry's done every Monday, for somebody who's dealing with incontinence, what can we do? What's the pathway to help them be able to wash their clothes discreetly if an episode happens, instead of having to wait, especially for folks who maybe don't have more than a week's worth of clothing or need to rewear their clothes. And then in congregate settings, these are just a few other examples, things to consider if people don't have their own private bathrooms, right? So can we position the person in their bed close to the bathroom or the hallway so they don't have to go as far if that urge happens? Making sure that you have an accessible stall for people with mobility impairments, again, to increase safety, using a grab bar, things that will support the person being able to safely get on and off the toilet, that can actually decrease some of that anxiety that's contributing to the incontinence. And then if you're sort of collaborating and working with the shelter program, some training for your staff and the shelter staff, especially for folks who are not medical providers. And really this can be incorporated into regular trauma-informed care work because it is such a personal topic for folks. But how do we approach this with dignity and how do we support people instead of sort of ostracizing them? And again, if you're a program that has more individual rooms and private bathrooms, again, thinking about how you can increase the accessibility of your space. Some individuals who've come from a hospital might request to use a personal urinal or an in-room commode. And really, that's really only recommended in a respite program if the person can maintain the cleanliness and dispose of it independently. I don't think a lot of respite programs are staffed to really be able to manage that. So it's not recommended unless it's really dire or an emergent situation to do that. And again, just making sure that things are taken out routinely, the trash is taken out regularly, and that it's an adequate size for people to discard their supplies that they're using. This is an example of an accessible restroom. Again, it's not perfect, but it does have grab bars available and space for mobility devices to come in. So just making sure that people can reach the things that they need when they need to. This is a way to increase accessibility of toilets without doing a major overhaul of any restroom space. The one, I guess on the far left, it's just the handles. This is a really great substitute, especially if you don't necessarily have walls close by to install grab bars. It just adds handles so that a person can easily push themselves on and off the toilet and is pretty simple to install. The built-up commode raises the height of the toilet seat, which can be really helpful, especially for people who are taller or who have lower mobility limitations. And then the next one can be another great strategy. So that one shown there is the one that, folks might have if they come from the hospital and it might stay in their room. You can see the bucket underneath. Most of them, that bucket is totally removable and you can just put the seat and the grab bars piece over a regular toilet seat and they're adjustable in height to be able to do that. And so it's an easy way to add grab bars and raise the seat of the toilet seat, raise the height of the toilet seat without having to install anything. There's no screws required and they are relatively safe. So that may be another option, especially if funding is limited, to do some accessibility pieces here. And I want to talk about diet because this is such a contributor to incontinence for folks. And diet's really tricky in respite programs because we're not always in charge of where the food is coming from, and people certainly don't have choice over their diets when they're returning to homelessness. But if you can, especially if constipation is a contributing factor, having a high fiber diet to help just get the digestive system moving can then reduce some of the incontinence, give an opportunity to improve bladder health and really resolve some of that issue that's happening. And then thinking about where folks can get fiber adequately once they leave. And then identifying food and beverage triggers. So there's actually a lot of different foods and drinks that can be an irritant to the bladder. There's a whole host of them. Not all of them are going to contribute to irritation and incontinence for every person, but the people using that bladder diary can figure out what foods or drinks might be contributing to that so that they know to avoid them. And again, hydration. I don't think I can stress this enough about helping people identify and maintain really adequate hygiene routines. These is an example of some potential irritants and triggers. Again, in the clinical guidelines, there's a link to a list that you can use with folks. Again, not all of these are going to contribute for each person. That's why you have to do that individualized approach. I will note, though, that there's a lot of foods and drinks on here that might be used by folks who are trying to manage their diabetes and other health conditions. There's some fruits and vegetables on here, artificial sweeteners. So that can get really complicated and might be a good space for nursing or a dietitian to help the person identify how to meet these dietary recommendations for one condition, but also avoid irritating the bladder and incontinence. And then talking with providers, helping the person really be self-advocates, identify, how do I talk about this in a way that's not embarrassing? How do I tell them what's going on? How frequently? Again, doing that written bladder diary can be so helpful because the person can bring it to the medical visit and then they're not having to repeat themselves and just sort of say, look what's happening. I've been tracking it. That can also help move things a little bit faster in terms of care. And can advocate for referrals and an exam if the person needs it, such as if they need to see a urologist about what might be going on. That medication reconciliation piece, again, especially if the medical care is not happening in the respite program. And in some cases, there are medications that can address incontinence depending on the cause, certainly an antibiotic for UTI, but other things that might be happening. There are some that can decrease that feeling of stress and urge and irritation of the bladder that can really help people get some control and management. And then these are some specialty referrals, if accessible to folks. Certainly there's some limitation in accessing some of these resources here, but if the person is limited by functional mobility or functional limitations, such as getting on and off the toilet, undressing, other ADLs, occupational therapy can be a great resource. Physical therapy, again, to address mobility needs. Do they have the right devices? Can we do some strengthening to help in movement, increasing stability and decreasing risk of fall? And then there's also pelvic floor incontinence certified therapists. And this person might be a nurse, this person might be an OT or a PT. So you can actually make a specialty referral for that. Not every OT, PT, or nurse is certified in this. So you'll want to look for a specialist, but this is where they can do a more intensive physical function exam especially of the pelvic muscles and learn some of those pelvic floor exercises to help improve their pelvic health. Written below is just a resource as to what you would need to include in a referral for that. The tricky part might be identifying who these providers are in your community and whether or not the person's insurance, if they have it, will cover it. And then again, resources folks for underlying conditions, especially if there's conditions that are uncontrolled contributing to incontinence. Again, a dietitian, especially if there's other health issues going on, that it's really complicated to figure out what's good for this person to eat or drink. And behavioral health, if they're not engaged already, to address stress that may be contributing a history of trauma, anxiety, and any other health conditions. And then finally, when we're thinking about discharge for folks, thinking about what is the long-term plan to access supplies and for people to take care of themselves and take care of their clothing to mitigate some of these issues, to be able to clean themselves, clean their clothes. What resources can we connect the person with in the community to do this? Who is the provider that's going to follow up on this? Is it their primary care? Have they been referred to a specialist? If it's not fully resolved before the person leaves the respite, who's going to manage it, or who can they talk to if this exacerbates and occurs again? And then training the person to manage it within the shelter setting. So shelters are not always accessible. They're can't guarantee that they're going to be close to a bathroom. So what strategies can they use to manage in the setting that they're going to be discharging to? It's going to include in the housing setting if the person has access to that as well. And then what happens if the incontinence is not resolved or the person's unable to manage the incontinence? And if they're unable to manage it, there may be something bigger going on. If that's identified in respite, that then may become a reason to refer for more intensive care that wasn't identified in other spaces. So this is just an example of a self-management plan of what it might look like, especially if you're working on it with someone in respite, right? So if the person wants to reduce the frequency of needing to urinate, they might do that bladder diary and then identify that coffee is a trigger. So they're only going to drink it in the morning and just drink water throughout the day to increase hydration and to reduce some of that. And then also using that voiding schedule of going to the bathroom every hour. If I have a week with no accidents, and the next week I'm going to push it back by 15 minutes. A similar client goal, if somebody wants to reduce the leaking that happens before making it to the bathroom, again, checking the bladder diary, thinking about frequency, going to the bathroom every hour for a week. If we make it with no accidents, then increasing that time between using the restroom. And then using that strategy to suppress urge, take a deep breath, and walk slowly to the bathroom. And if you're really interested in diving into this and really treating it within your respite program, there's certainly some certifications that can happen. Learning about pelvic floor exercises and rehabilitation, biofeedback and eSTEM are also used for, can be used, especially if people have those certifications to be able to do that. And then thinking about if we need to dive in and do some more education on medication management for managing incontinence and preventing that. So I have left 5 minutes here, which is more than I thought I would have. So I'm excited about that. So I'm happy to open it up for questions. This is just a list of our resources here, again, from that initial link I shared about all of our clinical guidelines and recordings here. So I'm going to stop sharing my screen and just open it up here for folks if we have questions or comments on this topic or any of the ones that we've discussed over the last couple of weeks. And I'm also going to throw in the chat a link to our survey for today's webinar, if you would also please fill that out as well. And any programs willing to share if you've addressed this or any barriers that you've experienced around this in your programs as well. I'm interested to hear that in our last couple of minutes here.
I think one of the, can I just speak? Or
yes, go ahead. No, go ahead.
So I'm Amy. I'm a nurse practitioner from Minneapolis, Minnesota. And our respite program pre-COVID was shelter-based, so directly in one particular shelter in Hennepin County, serving adults. And I think the hard part in helping with the management of incontinence, particularly, I think, in a shelter-based program where we're providing care to all residents within the shelter, as well as people who are unsheltered who can come in there, in addition to a respite program within the shelter, is that we are the medical clinic that is housed in the shelter, and essentially the shelter providers are the people then who have the existing conditions, I should say, for people staying in shelter. And we often, like last minute, get somebody brought down and told by shelter staff they aren't going to be able to stay here anymore because of their incontinence. And that's a really tricky and challenging position for all of us to be in, client especially, because it's essentially reactionary versus proactive attempts to try to manage it. In addition to it always, I mean, this incontinence management is often something that happens as we get to know somebody. It's not something that a conversation is opened up with. And so I would love some ideas and thoughts on kind of that reactionary approach to the management, knowing that, you know, it's like, this is the last ditch effort, please, you could do something or they're going to get kicked out. And that seems horrible on so many different levels, but yet it isn't a situation where you can fix it within one visit often. So if anybody has any thoughts, or I know it's not an easy answer, but maybe approaches to that.
My first response, and I'll let other folks jump in too, is sometimes the first thing is just supplies. Like, can we mitigate this by, you know, if we have supplies on hand for the person, just so that if it does happen overnight, it's not, you know, getting on the bed, getting on the sheets, like this sort of public thing that happens, that everybody becomes aware of it, and then it becomes that, for, you know, that strike that breaks it. Because I think that's one of the biggest barriers, is the access to appropriate supplies. And it can be done immediately if those are on hand, if the health center can just sort of keep a stash of them for folks, versus doing some of these more long-term developing routines and strategies and and with that, which is really hard. And I think the other thing too is asking the person like, who's probably very embarrassed in that particular moment, you know, what would you like to try? Like, how do we want to handle this? What is your choice at this moment? And trying to empower them a little bit in a situation that's really disempowering, I think, for a lot of folks. But I'm interested to hear if anyone else has thoughts or suggestions. It's a great question. Stumped me.
No, that's not the case. But also the supply situation too, I feel like is a challenging one, just for transport and having enough to be able to have on person. So if somebody is only allowed to be in shelter to sleep and then needs to be out during the day, having enough of those supplies and being able to carry them, that has been a struggle too. So we do supply supplies. I also can get them through DME, through various insurance companies can provide it, but it's, you know, they come in huge boxes, and then where do we store all of that? So
yeah, and some of it too might be sort of in the background work, working with the shelter to think about, you know, if we have these supplies for folks, where can they get them discreetly again throughout the day, and thinking to like not just providing the Depends or other supplies, but the plastic bags to carry them in, or the backpack, you know, kind of thinking whole picture with that. But yeah, it's really tricky. And I agree that that shelter space is really hard. And I think people's first reaction to incontinence is that it's a behavior and that's something somebody might be doing on purpose, which I think is why it's so frustrating for providers in settings to see like, oh, why is this person doing this, and not recognizing all of these things that might be contributing to it. So, and someone pointed out in the chat, they use their CNA to assist in toileting and asking if clients would like to wear the adult Depends, which is a great suggestion. So I do want to recognize it's 3:02. So we are at our time. Thank you so much, everyone, for joining us, sharing your questions and ideas here today. And we look forward to seeing you at future medical respite events. Thanks, everyone.